All right. Thank you, Ali. We do appreciate it. And thank you to the Indiana Rural Hospital Association for inviting us to do this. So we are looking forward to sharing our information. So we are Fedko physicians. We staff and manage emergency departments and acute inpatient or hospital service lines. So just want a little background there.
Yeah.
Um, um, and I'll have Marty obvious switch that slide there next so we can introduce ourselves.
Yeah.
I am Randy Anderson. Um, My background, I was a hospital CEO and regional vice president for 26 years, majority time spent up in the upper Midwest and the Southwest. So,
Yeah, I'm Dr. Fedko. I'm also in the Midwest. I trained at Mayo Clinic in Rochester, Minnesota. And Randy and I started this about 10 years ago. We primarily focus in the small rural markets in terms of where we staff and the successes we've had. So,
all right. So let's talk today. So that's what we're going to do. So the emergency department is a major driver to your front door and a primary driver of your inpatient service line. So our objective today is to show how the ED performance affects your total hospital operations, how it generates and captures revenue, and then the community perception. From an executive level, what we want to focus in on is throughput, your patient experience, some of the capacity constraints, and then accountability. And like Dr. Fedko had mentioned earlier, that this can affect hospitals anywhere from, the low volume hospital EDs for 5,000 ER visits or less up to 35,000 ER visits. So I hopefully there's something you can take away for each of the sites. And so why does the ED matter? Volume and admissions, you know, according to CMS data, inpatient volume you can generate between 12 and 14%. And then in 2021, and I apologize, I don't have any updated CMS data, but we can take this and maybe update it a little. But back then, there were 130 million ER visits nationwide, and 35 million of those were injury related. So there's that delta of what we call the walking wounded, who maybe didn't need to be housed in the ER, but they came in and maybe got a Band-Aid or, I'm simplifying that, but there is volume out there to capture. And then 40 out of 100 people visited the ER across the nation. So if you look at your own community and say, okay, based on my volume, 40% of those people will visit your ER. And so for executives, the ED performance is a marketing positioning lever. Experience and wait times will influence whether patients come back to your ER, whether they recommend you, or they accept our inpatient and specialist referrals that you may have. So from your perspective, you need to determine what we're trying to do. Are we trying to just maintain our current ER volume? Are we trying to grow? You might be next to another market where you're trying to capture new volume. One of the things that really affect an ER is patients are increasingly mobile and they have no problem traveling out of your market and they'll go to another market next to you if it's perceived to be better experience. And we've seen that in our own hospitals that we've staffed in other states and we're across the nation where if they perceive the quality is not as good in their community, they'll drive over to the next community and visit that hospital. And so perception really is a big deal.
yeah, we've had like 30 to 40% volume growth just based off of that at some of these facilities. And in the strategic planning meetings annually, they've found that it's market share capture out of the other markets. So,
Right. Yep. And then there's also competing I should say, real substitutes for going to the ER. Of course, urgent cares are popping up all over. Telehealth has been around for quite some time now. And luckily that I was involved in some of the earliest telehealth development where we had test markets and it really did pay off for us. And then you also have the retail competition where the big box stores such as Walmart may have a small clinic, or a Walgreens may have a small clinic. And the last thing for large employers, they have incentives for their staff not to go to the ER. And so they may have their own micro clinic at their facility where they'll have patients or employees come in and see if they need to go to the ER or not, or if they can just fix it right there. So you have competition out there that had never existed before, probably in the last 20 years. And so really what you do is you have to think of the patient experience that begins out in the parking lot. And so, the appearance of the facility equates to quality. And so, when your patients are coming to the ER, is the sign fairly new? Is it fairly visible? Are things painted? Is it clear from brush or trees? But um, they see that if it's clearly marked with concise signage, that reduces stress and confusion for them. When they're already in a state of disarray, you're not seeing these people at their best. First impressions make a difference. Is it clean? Is it up to date? Is the exterior up to date? Or in the interior? So these are signals that there's clinical reliability. And then, of course, the human touch. What is the greeting like when somebody comes in, and is it an empathetic situation? Even through registration, it reduces that perceived chaos that they're feeling and any friction that may exist. And so, reduction in chaos equals high quality. So there's an instant dissatisfaction. So basically, here, um, there's wait times and perceived wait times. People come in and they want to be fixed now, so time is of the essence. What you want to do is manage expectations early. So explain the process, even during registration. Here's what's going to happen, and then be realistic with timeframes. If you say it's going to be 5 minutes and it's 10, you've already had a dissatisfier, and now they're not happy. Make visible progress. Keep patients informed and feel that they keep moving so work feels active. And a great example of that is how Walt Disney does it. They put you in a long line, but they keep waiting, and you feel like you're moving or making progress. And the wait time may be the same, but you're moving. And that's what they want to know. They want to feel that something is going on that's active. Another thing is we've heard over patient satisfaction that they would say, well, the staff were sitting in front of their computers and they were doing nothing. Well, you have to explain to people what they're doing in front of those computers, filling out registration or ordering labs or radiology. But again, it's all about communication. And these are all touch points, uh, and the number of interactions that you have with that patient, they feel like they're really being taken care of.
Yeah, so our facilities, we've mandated our providers going there at least 2 to 3 times, no matter how small or how large. Throughput's a very big deal when you get to higher volumes, 15,000 and up, in terms of creating a vertical and a horizontal zone, and that kind of gives that Disney appearance, but at the same time keeping us efficient as well. We'll talk here shortly about throughput metrics. And so on the throughput metrics. The number one thing, and a lot of people I think miss the boat on this, is the door to discharge time. 80% of the patients are getting discharged. They really are. And so your overall length of stay really matters. And if you can shorten up that door to discharge time, that will shorten up your overall length of stay. And that will make more beds available for those horizontal patients lying in bed who are much more likely to be admitted, the truly the sick ones that are going to be coming to the hospital or need to be transferred. So door to doc times are big. To providers getting to a patient within the first 5 or 10 minutes of arrival, whether it be an APP or a doc, putting hands on them, getting orders in, and then having them go through the system. And like I said, it's very volume dependent. If you're 5 or 10,000 volume, it's a single provider system. And so those are very big from a patient safety perspective, but also a patient satisfaction perspective. And then you also have, metrics beyond that, which I'm sure everyone's heard of it from a clinical perspective, in terms of lab and radiology turnaround times. Can you get adequate physician coverage? Sometimes we have some issues with that across the nation where you see a lot of providers, it's hard to get them. Same with nursing staff or say radiology, ultrasound techs are hard to get, so you don't have ultrasound available certain times of the day. And so those things can be dissatisfiers to patients.
All right. So, ED throughput is a basically a hospital-wide constraint problem, it all bottlenecks. So it's not just an ED problem. So delays are frequent, created by, diagnostic delays, radiology delays, gaps in staffing possibly, or specialist response times. So if you're waiting for a specialist to get back to the physician that ordered something, they're probably busy as well, which creates a delay in care, and so the patient again perceive nothing is going on. You also have like the first bullet there, the arrival variability. You have the walk-ins, of course, through the front door that go through the registration process as normal, but then you have an ambulance may show up in the back, and they just don't see that. They don't see behind closed doors that you may have an ambulance or two show up, and then it could be something stat that all hands on deck, and you're running to that ambulance to take care of those patients. Like Dr. Fedko mentioned, there could be staffing constraints. And we see that, radiology constraints, we're waiting for a radiology read to get back to us, and that physician is probably remote somewhere and they're reading it, waiting for those results to get back. Provider supply constraints, like Dr. Fedko had mentioned, the physician market can be slim in some areas, and specialist coverage isn't also a difficulty. We manage and staff some very difficult hospitals in some very rural states. One of them is New Mexico, and that's a challenging market across the board. And luckily, we've been very successful there. And then the environment, it could be chaotic, but the perception is you have to make it feel controlled, And again, the patient equates chaos to poor quality, even though it may not be true, but that patient feels if it's chaotic, then, I want to go somewhere else. So, from an executive standpoint, we need to make sure that we manage that in a calm manner. We've also had questions from patients and just consumers alike in the community about why does the hospital outsource its ED? Well, there's many reasons. The simple one is the inability to hire physicians directly, and then the inability to effectively manage those physicians. We've had experience where there's physicians that have been in the community for a long time, and they may be good physicians, but they could also be disruptive. And because they're the only game in town, they think they can exhibit sometimes behavior that's not appropriate. And so you need to take out that variability and hold accountability, and then don't be afraid to make a change. Perception that performance is the same everywhere is not the same. We got to define expectations. And then it's difficult to make a change. The limited alternatives to change providers, finding a good group or a good, physician can be difficult. And there's a cost to switching groups. There's tangibles where that's just additional outlay, but in the long run, you'll get that money back. But then there's the intangible, which is the behaviors that are difficult to measure. And at some point in time, you just can't tolerate bad behavior. And so, from an executive perspective, in today's market, settling for poor performing physicians or providers is not sustainable. Your ED will start to suffer, and those volumes will go somewhere else.
And I think if you partner with the right group when you're outsourcing, the goal is to take the headache away. I mean, make sure the ER is fully staffed with consistent providers, who are accountable to the community, who participate in medical staff, et cetera, and who are really, buy in on the facility and the community. That's really important. So I think if you partner with the right group, a lot of those headaches get removed that you would have to undertake when you go through an employment model. So.
Yeah. And whatever, whether you're employed or contracted, your expectation should be the same.
Great. Yep.
So this is the control playbook. We have to reduce variation and set expectations and create some type of transparency so the patients believe in what you're doing and they have confidence in your hospital. So train the full care team on your patient interaction. So do some role playing. Go back and role play a difficult situation and see how things could have been different. And then anticipate some stress behaviors from your patients because, again, you're visiting them at not their best time and they're already stressed. And so, how can you calm that patient to create a better experience? Standardize the arrival and registration processing and messaging. The folks behind the door should understand what the registration folks are telling the patients and defining expectations and the priority rules. When something comes in the door, what's the priority? And then expected timing of how the process should work. Physician accountability, we've talked about that. And that's one thing that we're really strong is about physician accountability. And it's now different than all of us that are on the call. I mean, there is expectations of all of us, and then we're accountable for those expectations. So again, define those expectations. Monitor the throughput of the patients. You should have a board in your ER or through your electronic medical record that can help monitor how patients are moving through the system. And then, of course, recognize the desired behavior that you want. Everybody likes to be recognized amongst their peers. And so it's important to do that. And then they will repeat that behavior. And their team-based care, of course, the physicians and the nurses need to be aligned. Most of the time that happens, but sometimes it doesn't. And then it's okay to communicate what happens behind the door when you're a patient sitting out in the waiting room and the doors are closed. Just the curiosity alone of why you're sitting out in the waiting room and not in the back exists. So, but tell people what's going on behind the door, that you might have got an ambulance come in and our staff is busy right now.
Yeah, you'd be surprised how understanding folks are, especially in the smaller critical access hospitals in those communities, how understanding they are when those situations come up.
Yep. Yeah. Um, well, I think one more back. Can you go back, Marty, for a second? Okay. And then on the bottom there with leadership, administration and physicians, agree on what's to be tolerated. There's got to be a little bit of variation around the expectations, but the majority of it should be the same. Define what resources that you need in your ER so it can be efficient and create that downstream revenue for you because it's such a big deal at being the front door of your hospital. And then escalation. What items get escalated up and which ones don't? And so, I mean, you can't yell fire all the time, but determine what needs to be brought to the top and what doesn't need to be. And so here, what you want to do is you define what you want in your ED. What are you going to look like? And then what's your capabilities? We're not all going to have every specialist available at our fingertips. And so define, what you're going to be. Define your boundaries based on your specialty coverage. If you have hospitalists in-house or if you transfer to a tertiary center, you could be part of a system. Define your nursing skill set. How deep do you want your nurse's skill set to be? And I think it's important, and nurses take time in investing in their own skill set as well. You may have a cath lab, or you may be part of a system that has a cath lab where you're going to transfer. OB, are you going to be an OP provider or or sending OB out to your tertiary center? What type of urology services will you have, or GI or ortho? What you want to do is reverse avoidable transfers, review that transfer log every week, and then target the things that you transferred out and see if you can keep them so you continue to grow your ED, and then it also helps your hospital. Organize your provider mix. Determine what your bylaws will allow. A lot of places now allow APPs to operate independently or with the supervision of a physician, depending on the state. And then align that staffing to your demand patterns. What we try to do is demand or outline our staffing patterns based on RVUs.
Yep, RVU arrival. So a lot of people focus on patients per hour, but that doesn't tell the whole story of what's going on in the emergency department. When you look at critical care time, intubations, something as simple as a splint, which is time consuming, or a laceration repair, which is time consuming, the provider's time is being occupied. But those are also higher RVU procedures, and they generate more RVU. So if you look at RVU that arrive to the emergency department by hour, and map that out. We have a TOPS analyzer we do this with, but that'll allow you to get an optimized staffing plan. So a lot of people like to go off of patients per hour, even the physicians do, but it's really about RVU per hour arriving to the ER. So.
Right. Then, when you're also determining what you're going to be as an ER, remember that the financial folks need to determine, what type of collections you will receive versus physician seeing a patient versus an APP. The billing models are different. It's usually a 15% reduction in payment if you're just having an APP model versus a physician. And then you can have a blended model as well, where we can coach with that, where you have an APP see the patient with a physician follow-up, and then you can bill from a physician's perspective.
And then also some snags we've seen over the last 10 years is when a ER physician admits to themselves on the inpatient side and billing complications with that because you can't bill for both services apparently. So,
Yeah. And then, align all your leaders with your priorities, whether you're part of a system or independent. Everybody needs to know um, what page you're on, and then the metrics that you're going to measure, and those will expand and contract as you get better. And then just the accountability cadence. Again, at the end of the day, it's about accountability and having your system survive. And so this is our contact information, but we are ready for any questions that you may have. And so Allie might open it up.
Absolutely. I have not yet seen any come through the chat or Q&A, but obviously we'll give you a few minutes here.
Yeah,
Similarly, as I said, if you want to ask your question verbally, just raise your hand and we will be able to take questions that way. We can unmute your line. Also, I bet you guys are going to be surprised. We've got a post-session survey. Again, extremely important for us to collect this data to be able to continue having sessions funded by the Flex program. So if you could take just a second, only 2 questions this time. Hope that you'll take a second to fill those out.
yeah, and we appreciate it too. We want to know.
yeah, and we're happy to answer any questions or give you any examples of what we've done and the things we've done in the past. So, to put it all into a half hour, 45-minute session would be tough. So,
Okay, well, I am not seeing any questions come in here, but we'll go ahead and end the recording.